And very excited to welcome PGY2 emergency medicine pharmacy resident Mallory McGee. Now, Mallory comes to us from Froedtert Hospital in Milwaukee, Wisconsin. You can find her on X at Mallory McGee 17. Welcome, Mallory. How are we doing today?
Hey Nick, yeah, doing pretty good. Excited.
Pharmacologic interventions, they're becoming a little more rare in cardiac arrest management. But one drug class is slowly gaining evidence for its use, specifically in shockable rhythms. So, Mallory, take it away.
Yeah, so really today we'll be talking about Esmolol and its use in refractory ventricular fibrillation or pulseless ventricular tachycardia. To begin, why do we care about this? Kind of like you had said, Nick. So there is an estimated 400,000 sudden cardiac deaths that occur annually in the US, with approximately 100,000 of these presenting with those initial shockable rhythms of ventricular fibrillation or pulseless ventricular tachycardia. To begin, of course, just to define those two things in a non-refractory sense, ventricular tachycardia can be described as a chaotic, rapid, asynchronous electrical activity of the ventricles, and this disordered activity leads to a high heart rate that does not allow adequate pumping of blood or an adequate cardiac output. Pulseless ventricular tachycardia, very similar. There is electrical activity present, but it fails to produce an effective blood pressure or any sort of heart rate that is compatible with life. But and this typically presents as a wide complex tachycardia with a rate of about or greater than 100 beats per minute. Now, what we will focus on is the definition of refractory ventricular fibrillation or pulseless ventricular tachycardia. And so, a little bit, some controversy around this is that it's not super well defined. In the 2015 AHA guidelines, their definition is simply refers to ventricular fibrillation or pulseless ventricular tachycardia that persists or recurs after one or more shocks. Some of the evolving literature definition, this is what most studies have defined these as, but this is pulseless ventricular arrhythmia that has persisted despite 3 defibrillation attempts, administration of 300 milligrams of amiodarone, as well as at least 3 doses of 1 milligram of IBF epinephrine per those ACLS guidelines. So now that we have a little bit of a background definition of that, we will move into kind of our phases of ventricular fibrillation, which will help us understand perhaps where esmolol fits in. And I liked the definition that was used in an AGHP article published in 2022. And this describes 3 phases, with the first phase being the electrical phase from 0 to 4 minutes. And this is really disorganized electrical activity. However, your cardiac myocytes are still well oxygenated. The second phase is the circulatory phase from 4 to 10 minutes. And this is when you start to get that regional myocardial ischemia, a brief washout period of deleterious substances generated from ischemia, resulting in more effective defibrillation. But really, we'll focus on that phase 3 metabolic phase, which is greater than 10 minutes in. And this is where we may start to think of these refractory therapies. And this is where the body is really experiencing that global ischemia, increased levels of inflammatory mediators, and those high levels of both endogenous catecholamines and then those exogenous catecholamines that we have provided via IV epinephrine. And so thinking about that, this again is really where our role of esmolol will come in these refractory arrhythmias. And so esmolol really may blunt increases in myocardial oxygen demand and cerebral vascular constriction due again to those excessive beta adrenergic stimulation that is occurring from those high levels of endogenous and exogenous catecholamines that are circulating. A little bit of background, the first published use of beta blockers in this population was as early as 1966. There were a few propranolol studies looking at that. However, the first use of esmolol was first mentioned in a case report in 1991 for ventricular fibrillation refractory to defibrillation, lidocaine, and procainamide. And they use esmolol as a loading dose of 500 micrograms per kilogram. And then they followed that with a continuous infusion of 60 mics per kilo per minute. I also want to point out that the 2020 AHA or the 2021 ERC ACLS guidelines do not mention any medications outside of amiodarone and lidocaine for refractory ventricular fibrillation or pulseless ventricular tachycardia. So, of course, the fun part, if you're a pharmacist listening out there, we want to know about Esmolol and what are the kinetics of it? Why is it so special? So, the mechanism of action, it is an IV beta-1 selective adrenergic antagonist, and it's super unique in the way that it's quick on, quick off drug, and the onset is about 2 minutes with a half-life of about 9 minutes. And so, thinking about these kinetics is really what makes this more favorable in this population. Another fun fact is that it's metabolized by red blood cell esterases into a non-active acid metabolite and methanol, so it's not reliant on either our renal or hepatic clearance. The dose, which we'll talk about a little bit more in our studies, but really the recommended dose right now is 500 micrograms per kilo as an IV push bolus, and then maybe could consider a continuous infusion following that bolus, ranging from 0 to 100 micrograms per kilogram per minute. Thinking about Esmolol and the kinetics we just discussed, why don't we consider other beta blockers? So really, again, focusing on the key there that the kinetics are very unique, but there was a study first submitted in 2007 called the Shock and Block trial, and this was looking at the use of metoprolol in these tachyarrhythmias. Only 7 patients ended up being enrolled in the trial, so it was ultimately stopped early due to that poor enrollment. So it's a little difficult to kind of theorize that if we don't have a full study looking at the use of those other beta blockers. Speaking of studies, we'll just briefly summarize a few of the studies on the use of Esmolol. And just to preface, a lot of these studies have been conducted in the out-of-hospital cardiac arrest setting, so it's a little difficult to extrapolate to an inpatient setting, so just keep that in mind. A brief summary of just 2 studies. One was published in 2014 and another in 2022. But this included a total of 99 patients, 67 of which received Esmolol. And both of these studies trended toward showing benefit of Esmolol. However, neither attained statistical significance. We will then touch in a little more detail on 2 other studies, the first one being titled Esmolol, Vector Change in Dose-Capped Epinephrine for Pre-Hospital Ventricular Fibrillation or Pulseless Ventricular Tachycardia, that was published in 2023 in AJEM. This included 83 patients, again in the pre-hospital setting, and they were in ventricular fibrillation or pulseless ventricular tachycardia when they were actually enrolled in the trial, but they could initially have a rhythm of PEA or asystole. And they, again, did use the definition as we had kind of defined from the literature that patients did have to receive at least 3 standard defibrillations, 300 milligrams of amiodarone, and 3 milligrams of IV epinephrine. They looked at a standard of care group versus a quote bundle group, which consisted of 3 milligrams of epinephrine. They could get vector change defibrillation as at the discretion of the clinician. And then the Esmolol component consisted of 40 milligrams of IV push Esmolol, followed by 60 milligrams of the IV infusion that was given over 10 minutes. Their primary outcome was sustained ROSC, and that was defined as ROSC lasting greater than 20 minutes. They also looked at survival to hospital arrival, survival at hospital discharge, and neurologically intact survival. Looking at our results for that, they did favor the standard of care group for that sustained ROSC, with 58.3% of patients achieving that and 17% achieving that in the Esmolol group, which was statistically significant. Overall, however, they did not find a difference in survival or neurological outcomes at hospital discharge. They concluded that their rates of ROSC and survival to hospital arrival were higher in the standard of care group. However, with that, there was no difference in the rate of survival to hospital discharge or neurological outcomes. Our next study is refractory ventricular fibrillation treated with Esmolol, which was published in 2016 by the European Resuscitation Council. This was a retrospective study, again, kind of a pre-post phase, and this included 41 out-of-hospital cardiac arrest patients, and they did have to have initial rhythms of ventricular fibrillation or pulseless ventricular tachycardia. That included, again, patients defined by that refractory state of 3 defibrillation attempts, 3 milligrams of epinephrine, and 300 milligrams of amiodarone, and no ROSC after greater than 10 minutes of receiving CPR. Their interventions, again, kind of that pre-post, they looked at standard of care patients, and then their post-study looked at Esmolol, which was given as 500 micrograms per kilogram as that IV push bolus, and then this was followed by a continuous infusion of 0 to 100 micrograms per kilogram per minute. Their primary outcome was also sustained ROSC of greater than 20 minutes, and some secondary outcomes included survival to ICU admission, survival to hospital discharge, and survival with favorable neurologic outcomes. Their results in their standard of care group, 16% achieved sustained ROSC, and in the Esmolol receiving group, 56.3% achieved sustained ROSC. Looking at temporary ROSC, just for a little bit more granular data, again, in the standard of care group, 24% achieved this and 81.3% achieved this in the Esmolol group, which was also statistically significant. Their conclusion was that higher rates of temporary and sustained ROSC were achieved in the Esmolol group, and as well as survival to ICU admission in these out-of-hospital cardiac arrest patients. However, again, no improvement in neurological outcomes. Just to touch briefly as we kind of summarize the studies. So really the question is kind of around the rate of continuous infusion or if it would be used. These studies didn't really break down what rate they started at, how long they continued the infusion. Again, those ranges were 0 to 100 micrograms per kilogram per minute. So if you're at 0, obviously you're not using it. So it's hard to kind of tease that out. So that is still a question that remains as far as the use of the continuous infusion. Now to get to a little bit more of the fun part, just some pearls, thinking about the use of Esmolol and what you may want to think about in your institution if you're considering its use. And especially in the emergency department, some logistics to consider. So luckily, I'm a little bit spoiled in our main kind of area in the ED, our main medication dispensing cabinet. We do have both the vial of Esmolol as well as the pre-made, pre-mixed Esmolol infusion. So we are quite spoiled again in that case scenario, but not everyone will have this luxury. So that is definitely something to think about if you're in a cardiac arrest situation. Perhaps you're the only pharmacist there, that you're getting a lot of other orders and trying to prepare a lot of other medications. So just the logistical component, if you have to go find Esmolol from somewhere else, it's not readily available in your crash cart. That might be something to think about just logistics wise. The other thing, again, going back to that continuous infusion, if you have to set up an IV pump, there's a bunch of people in the room, you have to try to get that through there or even go find an IV pump. Just, again, something else to think about as far as that goes. This again kind of leads us into medication safety considerations. So I would also like to point out that the vial of Esmolol is in milligrams per mil, but our dose is in micrograms per kilogram. So there's a lot of math that could be going on in that, again, kind of chaotic situation. Just to preface that, so we don't lead to any unintentional medication errors. Just something else to think about, Esmolol is luckily compatible with a lot of our other ACLS or post-ROSC medications, such as epinephrine, norepinephrine, propofol, and fentanyl. If those drips have started, it would be compatible with those in an IV line. Just another little piece of information, the cost of Esmolol from the patient charge perspective, from what I found at our facility, the vial is $61 and the continuous infusion bag, which is 200 milligrams, is $533. So, kind of to wrap this up here, kind of our conclusion, and we put together a little algorithm here. So, I would consider the use of Esmolol in these refractory arrhythmias of ventricular fibrillation or pulseless ventricular tachycardia, as defined in the studies, with those 3 defibrillation attempts, if they have received at least 1 milligrams of epinephrine and also received amiodarone, or some providers prefer the lidocaine, but again, refractory to kind of our standard ACLS medications. And then I would use it as that 500 micrograms per kilo as the IV push. And then kind of with those questions still around the continuous infusion and thinking about the logistical considerations, I wouldn't necessarily push for the continuous infusion to be started. We're not sure when we would turn it off if we did start it. So just something to consider. I wouldn't necessarily recommend against it, but not something I would push for. And so thanks for listening, everyone. Any questions from you, Nick?
I like that we were trying to create the grand rounds perspective, except we're not having terrible hard questions being thrown and darted at you. So I love highlighting the medication safety concerns, not only the micrograms and milligrams, but just talking about the logistics of like trying to get a continuous infusion started in the code. That's a real kind of EM perspective, so it makes sense that you'd kind of come with that mindset. Now, from the algorithm, it makes complete sense the way it's proposed because that is how it's studied with the small data that we have. And we know amiodarone and lidocaine, we don't even have great data for those. But my question for you, do you think if we administered it earlier, could it be better from like a survival and favorable outcome perspective? Because when we think about it, our cornerstone of therapy, epi, works completely differently and completely locked, like the opposite of what our proposal of Esmolol would do.
Right. Yeah, I think that's a super interesting question that hopefully gets studied someday. But as we know, these are kind of hard studies to conduct a little bit. But really thinking mechanistically about where Esmolol is working, I think it could be beneficial potentially, especially if we're kind of going down the road of maybe a refractory patient, just to kind of counteract maybe the perfusion downsides of epinephrine, and maybe it could, in theory, increase kind of our neurologic function after these cardiac arrest events. However, of course, as everything or most things, there would, of course, need to be further studies to kind of determine that effect on maybe cerebral perfusion or just those neurological outcomes in general.
I definitely feel anecdotally it's going to be provider preference because there are some, if you're in these refractory cases, they'll tell you to stop all the epi and they're going to focus on
Mhm.
shocks. So when we get into like the dual sequential defibrillation, only other pearl that I have is because I've worked at a place that had no vial. If you're stuck with only the bag, sometimes you got to get the big syringe and needle and just pull out what you want to give, and maybe a little more volume than the vial. But sometimes beggars can't be choosers. But Mallory, what an awesome pearl, letting us learn more about a new drug and some of our most hands-on experiences in the ED. So thanks so much.
Yeah, thank you.